So next case is penetrating chest trauma. It's V31. A 23-year-old woman arrives in the ED following an assault. She has a multiple stab wounds to both sides of her pericardium and went into cardiac arrest in the ambulance 2 minutes before reaching the hospital. What are you going to do? So she requires an urgent resuscitative thoracotomy in the resuscitative bay in the ED. Why? She most likely has a penetrating myocardial injury with pericardial tamponade and may also have significant pneumothorax and hemothorax. Her loss of cardiac output has occurred within the last 10 minutes and has occurred in the presence of emergency services. Any longer and her mortality would increase exponentially. What might you find? Cardiac tamponade, massive hemothorax, massive pneumothorax, and hemomediastinum. Tell me how you will do it. I would begin by performing bilateral thoracotomies in the fifth intercostal space. Begin with the left anterolateral thoracotomy and extend across to the other side to form a clamshell thoracotomy. I would immediately open the pericardium anteriorly, avoiding the phrenic nerves. The sternum can be divided with either a giglissa or heavy Mayo and tough cut scissors. She has a tamponade. Now what? Open the pericardial sac along the long axis of the heart in inverted T shape. Evacuate the clot, digitally cover the hole, and then consider method of myocardial repair. If heart is in asystole or ventricular fibrillation, repair it quickly. If in sinus tachycardia, maintain digital pressure while performing repair. The patient will be required formal intubation and intravenous access. There is a hole in her right ventricle. What now? Ask your assistant to put digital pressure and you can mount the suture thioproline. Underrun the wound by horizontal metal suture to avoid oversewing a coronary vessel. Avoid over-tightening the sutures that will tear as the heart fills. The sutures can be augmented with pledgets if required. Foley catheter insertion sometimes can make this bigger after cut through. If the patient remains hypotensive, then consider descending thoracic aorta clamp placement to increase afterload and optimize cerebral and coronary blood flow. Elevating the limbs increases venous return and improves coronary filling and cardiac output. Once the heart is repaired, rule out posterior injury and begin internal cardiac massage. If ventricular fibrillation occurs, apply internal defibrillation once the heart is filled. Also consider inotropic support. Do not forget the internal thoracic vessels need to ligate. What would you make you abandon the procedure? Visible air in the coronary vessels, irretrievable injuries such as massive hemomediastinum from an aortic disruption, unable to fill the heart after 5 minutes, no spontaneous cardiac rhythm after 10 minutes, and unable to sustain a systolic blood pressure more than 70 or a palpable carotid pulse after 15 minutes. Thank you.